Welcome to Healthcare Forward, where industry leaders, benefit advisors, and healthcare professionals come together and discuss the changing landscape of commercial health plans. Brought to you by Roundstone Insurance, the first group captive for health insurance, where smarter self-funding meets long-term savings. I'm Mike Schroeder, founder and president of Roundstone Insurance. Well, welcome everybody. This is Healthcare Forward, Roundstone's podcast, and today I have with me Brandon Cornuke, Senior Director of Innovation at University Hospitals. Welcome, Brandon.
Thanks for having me.
Director of Innovation at a hospital. Why does a hospital have a Director of Innovation?
That's a great question. I've actually had Director of Innovation in my title at a number of different companies. This is the first time I've actually worked in a hospital, and it's different everywhere I've been, what that title means. What University Hospitals needs right now, what a lot of hospitals need right now, is the ability to change in the face of tremendous hurdles, lots of headwinds. And so my role as someone who helps drive innovation at UH is to really help drive transformation. It's really working to make sure the hospital has a plan and a path to go from where they are today to where they are in the future as fast as possible, with as little resources as needed to make that shift.
So let's talk a little bit about what is going on with healthcare and in particular hospital systems. You know, what's the landscape they're confronting right now?
Yeah, I mean, hospitals broadly have a ton of what we just called headwinds, right? Yeah. First of all, the landscape for the cost of healthcare generally continues to go up and up all the time. People are aging. People have less and less access to insurance. And our payer mix, at least at university hospitals, continues to be a struggle, right? That means that the folks who have commercial insurance versus the folks who have government insurance is a constant challenge for us, particularly because we serve a broad swath of the Northeast Ohio community. We have more than 28 hospitals. Our central medical facility downtown is more than 80% serviced by Medicare and Medicaid recipients. So we have a lot of financial hurdles to contend with. Also, there's a ton of uncertainty. Mm-hmm. There's so much uncertainty in the government's approach to healthcare right now, even with the new federal legislation that was recently passed. There's still ambiguity sort of swirling in that. I think most recently we saw sort of a federal, I don't know if it was a recommendation or a plan, who knows? But whatever's coming, I mean, that alone, the fact that we don't know exactly what that even means is a hurdle.
So the financial landscape is, I think it's fair to say, a challenge for hospitals. Yeah. And when you talk about payer mix, is that because the government pays less? That's the reason. Then the commercial plan pays a little more. I mean,
ultimately, that's the case. And now on average, that's not for every procedure and every condition. Mm-hmm. But generally speaking, the higher your government payer mix, the thinner your margins are. So
with university hospitals being at that 80% number, how does that compare to other hospitals throughout the country? Is that the norm, 80%, 20, or does it really change drastically throughout the country?
It depends, really depending on where you are. And I'll say that 80% is that's a ballpark number for our central facility. I think maybe hospital system wide, we're around 70%. I can't say for sure. That's not my direct area of influence, but I do know that we have a very large government payer mix in somewhere in the 70% to 80% range. And as that compares to hospitals around the country, I think that's fairly high. Mm-hmm. Just again, given the populations we serve, but not way out of proportion. Because we're a larger health system, we're going to obviously be able to diffuse that across lots of different hospitals and lots of different communities. Other hospitals that might have 1, 2, or 3 hospitals could have a very high commercial payer mix or a very low one, depending on the communities they serve. Mm-hmm. But generally speaking, there are an awful lot of people who depend on the government, especially those that seek hospital-based medical care. I mean, those are going to be people who have access to plans that cover, say, the elderly who are going to consume healthcare at a larger rate. So you're going to just see that more present inside hospital systems.
Makes sense. So I just looked at my notes to make sure I get this right, but there's some language in there called a smart hospital.
Yeah.
Yeah, so let's talk about that. What does that mean?
Okay. So smart hospital for us, I mean, we've called it the intelligent hospital. We've called it a connected care environment. We think that technology inside our hospital, so in the inpatient setting, meaning patients and beds inside our facilities, we have the ability to add technology to make their care better, the experience of our caregivers better, make our caregivers more efficient, by carefully applying a combination of older tech and cutting edge tech in creative ways to essentially make sure that we are as efficient as possible, but also delivering the best possible care.
When we're talking about this, I know you worked, and we're going to talk some examples about AI, but your innovation, it's more than just AI. I mean, you look for ways to innovate in a lot of different ways. Is that fair?
Yes, absolutely. Yeah. In fact, I would say we like to think about AI, just like any of these technologies, as possible solutions. We talk about, on my team, hypothesis solutions that really revolve around the problems we're trying to solve. We start with the problem and think out from there. AI just happens to be a tool that has tremendous potential to solve all sorts of problems. But ultimately, a solution is a combination of the best solutions are the combination of lots of different things. If you are a health system out there thinking, boy, we've got to apply AI, I would caution you and say, understand your problems first, because you will find a suite of technologies and capabilities and process changes that can address all sorts of problems. AI is not the answer to your problems. AI is a tool in a toolbox, a very powerful one that needs to be applied to problems.
So first figure out your business process, your business challenge, really get a good handle on what that is, and then figure out, hey, can AI or some other technology help us, address it?
That's right.
So don't lead with technology. Don't let that be the driver. Lead with what the challenge is. So.
And if you try to lead with technology, what I think you'll find is you'll be pretty intimidated by how to use it, because AI it's not specific enough to describe AI as its own tool set right now. It is a growing rapidly space that has all sorts of different tech tools and technologies within it. I mean, you might be talking about AI that's making algorithms more efficient, or agents that are becoming agentic and talking to each other. And those are completely different use cases for what AI is. So back to your point, have a really good understanding of the problems you're trying to solve. And you say business problems, we like to think about it in terms of, are they patient problems? Right? Are they caregiver problems? Are they financial problems? Are they our own problems? We try very hard to solve the problems for the people we're serving, and we feel like that solves our own business problems, but not always. You have to acknowledge sometimes there's just a financial equation that you need to solve with a more efficient technology, and that's okay too.
Yeah, we would say, what does the customer need, or what's going to help the customer out? And,
that's right.
We've had a bunch of different AI consultants come in and work with us, and we always start with sharing with them, this is the business challenge we're confronting, and can AI help us? And it's kind of a learning process for both the consulting firm and for ourselves to know, is this an AI solution that can be applied? And we've struck out more than we've connected. Now we're starting to connect a little better, because I think we're getting a little better idea of what problems lend themselves to AI. But it's still a back and forth, and it takes the consultant, for at least for us, a while to learn what the heck we're doing. So I want to chat a little bit about Connect to Care, because that's one of your AI tools or strategies. So can you share with me what Connect to Care is?
Yeah, so our connected care platform is a combination of microphones, cameras, screens, and software all put into a patient environment that allows virtual nurses that are not present physically in the space, to provide care for our patients and to support our in-person care teams as they deliver care.
Okay. Now, why is that a problem?
Yeah.
What's the business or what's the patient problem you're trying to solve?
That's a great question. I'm so glad you asked. We started with a pretty simple problem statement, which is we don't have enough nurses and they don't have enough time. And we know we will never have enough nurses at UH, never have enough nurses in this country. We are going to be 50,000 nurses short every year going forward for as far out as we can see. So understanding that our nurses are constantly going to be short-handed, short-staffed, and our nursing teams are going to be short-staffed, we knew we needed to explore technologies that could dramatically change that equation. A virtual nursing program allows a hospital system, or at least we believe it allows a hospital system, to put a remote nurse or a virtual nurse in a position where they can rapidly communicate and support everyone on a given floor or unit or multiple units, quickly supporting their teams or providing care in ways that in-person nurses have to sort of physically run around and operate. Mm-hmm. And when you add all those sort of little tasks done more efficiently, you find that you generate tremendous efficiencies. Also, we've found that our patients get better care and more attentive care because they always have access to their virtual nurse. Hey, virtual nurse, I would love an extra blanket, or I feel a little dizzy, or whatever their needs are, they're instantly met. Hey, no problem, Sally. I'm going to come in and have one of our nurses come in and take care of you. In the meantime, can I ask you a few questions?
Now, this is beyond an idea. You guys are actually doing this today.
Yeah. So we're on phase 2 of this experiment. We started with 135 beds across 4 hospitals and 5 different units. That included an ICU, several med-surg floors, and a step-down unit, and a peds floor, at least to start. That first phase was really to just get the tech working, to see if it was technically able to address these problems and stay up, right? You can't have a care team relying on virtual nurses and discover that the tech is only up 94% of the time. It's got to be up 99.99% of the time. Did we have the right vendor? Do we have the right buy-in from our floors? These are all sort of feasibility things in our experimental step 1. Experimental step 2 is to expand to an entire hospital. So we have this wired in an entire hospital in our Lake West facility. That's 5 additional floors, 135 beds. And that allows us to do things like provide virtual patient observation, which needs to have an entire facility because one nurse observer or sitter, some people might call them sitters, need to be able to go to any room in a facility rather than just one unit. That has unlocked tremendous amount of value for us because we've been able to show that a virtual patient observer can, instead of sitting 1-to-1 with a patient who might need a sitter, they can sit 1-to-5 or 1-to-6.
Wow.
And you'd be amazed at how much UH and lots of hospitals around the country spend on sitters, people who just sit in a room to make sure that you don't get up when you're not supposed to, or that you're responding well to medication or whatever it might be. Now, there's some situations where sitters are absolutely appropriate, situations where you might hurt yourself or others. We know we need in-person sitters, but there's a certain portion of our sitters that we can substitute with this. And this is just one use case among many. That's the exciting part, is that we're able to say, hey, this one use case saves UH a bunch of money, makes the financial equation for this technology makes sense, and yet it does all of these other things. I can give you some examples. We were able to reduce our sitter costs by 44% by using this a virtual patient observing platform. We've reduced our falls, the number of times someone falls, or the likelihood that someone falls, by 58%.
Wow.
That is a huge number. Falls are extremely costly to a system, and when we're able to demonstrate things like that, we're able to demonstrate not only better care for our patients and a better experience for our caregivers, but a financial equation that makes sense for the executives who have to run the enterprise.
That's helpful. That's why you do it. Now, are these virtual sitters in the building?
Great question. So how are we set up as a virtual nursing or virtual patient observer team? Well, we're set up in a command center. So we have an executive building. It's actually in Shaker Heights. We have gathered together our nurses, our virtual nurses and our patient observers into one central facility where they all work side by side, caring for patients all around our system in these pilot units. We've found that does a couple things. One, we're able to rotate our nurses in and out of those positions. So one day you might have our nurse who comes into the room and helps you in person, and then tomorrow you might see her or him on the screen and know them, right?
Really?
And that has been really important for buy-in from our patients. It's not just a nurse that we outsourced from who knows where, who just kind of steps in to do routine tasks. This is part of your care team, part of the people you trust, and that has really gotten a ton of buy-in. I talked about earlier how important it is for hospitals to have a plan in terms of how to drive change and transformation. Part of the challenge is that change is really hard and people resist change, right? They fear, our caregivers love their patients and they don't want to put anything between them and the best possible care. And anything that looks scary or weird or change that doesn't look right is going to get a ton of pushback. So we know we needed to get a lot of buy-in. So that the way we set up our teams and where they sit and how we rotate them in is really important. We've also found that as caregivers sit with each other in virtual nursing cohorts or sitter cohorts, they learn from each other and they're able to pull each other in and say, hey, what would you do in this situation? Oh, hey, can you help me watch this patient? And there's a ton of learning and a ton of efficiencies.
Yeah, that makes sense. We, as you are aware, we are hybrid, which means our folks come to our office a couple days a week and some days they work remote. But a big driver for making sure they get to the office is that collaboration, because if just the way those nurses are learning from each other the same way our employees do. What's the feedback from the caregivers? Do they like that time they spend in the command center, or are they kind of still a little bit uneasy about it?
So they love it. They love it because, as I'm sure you know, nursing is as hard a job as there is. It is physically demanding. It is emotionally demanding. And when you get the opportunity to go into a virtual environment and have a different relationship with your patients and your caregivers without the physical demands that requires, it's a real game changer for our nurses. And when we talk about not having nurses, there's another benefit here, right? And not having enough nurses. There's a real benefit to the idea of making the job just a little bit less demanding, and that helps us keep nurses longer. We've had nurses, instead of retiring, say, you know what, now that I can do virtual nursing, I'll stick around a little bit, or maybe I'd come out of retirement to help in these settings. So we think there's a real benefit to this idea of creating more accessibility for the skilled caregivers that we might otherwise lose.
Yeah. I have a few nursing friends and folks that I work with here that were in environments that were very stressful, very challenging.
Really
they, think like an emergency room or operating room, that kind of stuff. And they find that the insurance company environment, it's a little quieter. So I can imagine offering them a chance to have a little slower pace, or at least a little less demanding pace, would be attractive, no doubt. That's interesting.
It is.
Huh.
I did want to mention, you mentioned something earlier about AI, because I kind of put this technology in place, but I didn't really pay off their question around like, how's AI involved in connected care? And I just want to make sure we touch on this. It is a part of our test in the sense that we've looked into software that not only allows our nurses to engage with folks really easily and kind of be in a multi-view setting. If you're familiar with Zoom or Teams or anything like that, it kind of looks like that for our caregivers, but it's much more sort of appropriate for a healthcare setting. We've applied AI as a filter over the top of that to help, for example, point a nurse's eye towards a patient who might be getting up, right? To say, oh, you know what, we're going to highlight this box among the maybe 12 boxes or 15 boxes you have in front of you as someone who could potentially be getting up because our AI has captured some movement that suggests they will do that. We discovered that AI didn't really add any benefit once we got our nurses trained on that. And they said the boxes were kind of distracting and not needed. We're not giving up on AI in the connected care environment. There are tons of wonderful examples where we'd like to apply it, but this goes back to one of the fundamental tenets I mentioned earlier, which is solve the problem you're solving with AI, not apply AI to every problem, right? And this is where we found that even in an experiment, which we ran, and it was costly and painful and hard because it was brand new, we discovered it's not a value add in this moment, and we were able to make real strides without it. I've got a lot of good examples where AI is absolutely killing it for us, but in this particular case, we used it, but we found that it was more efficient to move on without it, at least for that use case.
Well, let's chat about where it's killing it for
Yeah.
you. You know, AI, I know you have some other success stories where you're applying it, so why don't we grab one and chat about it and see how it's working.
Yeah. So AI is, and as I mentioned, I mean, it is the behemoth in the room when it comes to innovation and transformation right now.
This is our second season of this podcast, and if I went back and counted how many times it's come up, and I talked to all different types of folks doing all different things, and it's always at least a little segment of the conversation.
It has to be. It has to be, and it will continue to be. This is not a flash in the pan. This is not. I know we've seen a lot of. I know you have, and I have. We've seen a lot of innovation trends come and go. You can name several, and RFIDs and all these things we're going to promise to change the world. Blockchain, and they're kind of making changes. But when it comes to AI, this truly is a paradigm shift in terms of efficiencies and operational gains. We know, however, that as a hospital system, we have to lean into this technology very, very carefully for a lot of reasons. One, you can't just go out and say, hey, let's just have AI answer all our patient questions and let them diagnose all of our patients. I mean, that is the height of irresponsibility, right? We have highly trained caregivers who have vast experience, who will do far better even in tests today than an AI can do, just kind of one-on-one. And on top of that, the risk to that is still really, really high. We need to build up to that sort of thing over time. What can be done, however, is hospital systems can find use cases where there are low risks to patient outcomes or safety, high financial gains, and easy implementation steps to allow you to dip your toe in and experiment to determine that you not only can get these technologies to work, but you can get them to pay off. And that's what we went and looked for. So I'm going to violate something I said earlier, which is always start with a problem without thinking about it. We kind of said, let's look at the landscape for what these AI technologies can do and reimagine the problems that we go to find. So we kind of let AI sit in the background and say, where are the problems that fit these early thesis criteria, right? The thesis around got to drive ROI, revenue generating, hopefully, low risk to patients, easy to implement, kind of doing what I call, I saw some tweet once that said, I don't want AI to do my laundry so I can do my art. I don't want AI to do my art so I can do my laundry. Right? That's a really important thesis for us. So one thing we found was that in our pharmacy team, we write thousands of scripts a week, thousands and thousands. And very rarely do our care teams say, hey, did you know that UH has a pharmacy that can ship these right to your door? Would you like us to write this script directly to the UH pharmacy and tomorrow you'll get it, get this shipped? They'll say, what do they ask? They ask,
what's your pharmacy?
What's your pharmacy?
Yeah.
Well, turns out 50% of our patients at least go to external pharmacies.
Yeah.
That is a revenue. I mean, you run a business. If I brought you this use case and I said, we're sending half of our leads to external, or to our competitors, what would you say?
That's an opportunity.
Let's close that bucket, right? And that's what we did with AI. We said, well, there's a huge list of patients that use medications. Let's find the ones that are most likely to want to switch and really see the value and benefit to their coming over to a delivery model with high margins to those medications, and see if we can, just as an experiment, reach out to them and see if they'd like to use UH's pharmacy. And oh, by the way, if you do use UH's pharmacy and you use our caregivers have visibility to the medications you're using and are much better informed about how to care for you with those medications. And so we've reached out to thousands of patients, found that a huge number, using an AI tool, right? Using a vendor who's specifically built their tool around clinical conversations. They have trained their model with what they basically say is all written medical knowledge, 180 IQ, and all the empathy you would ever want in a nurse. Okay, like who wouldn't want to talk to this person?
Yeah.
Reach out to patients and say, with this agent, this agentic tool, and lay out the situation. Hey, we've noticed that you have a bunch of medications with us. We'd really love to be able to deliver those directly to you. Would you mind if we had one of our pharmacists transition this to UH's pharmacy, and we'll have them shipped right to your door? And we are getting, now the crazy thing is the hurdles to get someone to allow this conversation to happen include things like, hey, I'm an agentic concierge calling on behalf of your physician. I would like to talk to you about your medication. Do you mind providing me your name and birthday?
Yeah.
Now,
Everyone assumes it's
yeah.
yeah.
Everybody's like, my first thought was, no way are people going to permission us to be able to get into a conversation with them about pharmacy. Turns out half of the people we got on the phone did.
Yeah.
And this is calling people the old-fashioned way. We're just calling people on the phone.
I can probably provide some insight. Part of the reason that's the case is the interaction with the pharmacies is so annoying that a lot of people are looking for an easier way. The amount of communication and confusion that these pharmacies create, I'm talking about the third party, is a pain point for a lot of patients. In fact, I am one of those patients that in the last year or so switched from the third party pharmacy to the provider, the hospital pharmacy. One of the areas is you also have to teach the caregivers. Because, like, you know, my primary care immediately wanted to send me to the local pharmacy, and I'm the one that spoke up and said, you know, I really want to keep this in house. That way, you have a little line of sight into what's going on, and the fact your pharmacy doesn't bug me the way my local pharmacy bugs me with all the texts and communications and the upselling going on. And so over time, he's kind of figured it out, and now my prescriptions will go through the hospital's pharmacy, and you know I have to say they do a good job. I mean, their service is top notch. So yeah, that's where AI, I guess, it helps out in making that happen. Have you seen any traction on that 50% leakage or no?
Yeah, we have. We've found that for every dollar we spend on the tool making calls, we make $20 per year in return in perpetuity.
Wow, that's fantastic.
20 to 1. And this is what I meant earlier by looking for low risk, revenue generating opportunities to explore with AI in really easy ways. We didn't need to integrate with our environment, and integration is this term we use in healthcare innovations to talk about taking external tools and adding them to our Epic environment, right? Our internal systems that are it's really costly to do that. We could do that outside of that integration cost and need. So there's really cool spaces where I think your audience and folks out there thinking about doing this can find ways to experiment with low hurdle opportunities. From there, we've been able to say, well, what are all the things that we can do next to start to lean into this idea and expand from that tiny little beachhead? Because right now our executives are saying, well, that worked great.
Yeah.
What else you got?
Yeah.
And we're saying, well, guess what? We send thousands of people a month home in a program we call Meds to Beds, which is when they're in the hospital and they're about ready to be discharged, we just bring their medication to them in a bag with all their instructions and say, here you go. And when they get home, we call them with this agent and say, hey, by the way, would you like us to sign you up for, it's just part B to the part A that we've already described. We're looking at ways to close what we call open orders. So open orders are things where imagine you go in and you say, hey, my arm hurts, and your doctor says, better get that looked at by a radiologist. Put a radiology order in, right? Get an x-ray or take a look. And you go home and we never see you again for some reason. For some reason. Maybe your arm stopped hurting. Maybe you tried to make an appointment, you couldn't get one, and you went to the competitor down the road. Maybe you're just suffering with it. Now, those open orders never get closed. They just sit there in our system. We can use an agent to go out and have a conversation with you. Hey, how'd your arm doing? Did you ever get that taken look at? Oh, you did? You had that looked at by someone down the road, great, we'll close it. Oh, you didn't? We'd love to have you come in and get that taken a look at. Because I can tell you, yeah, when your arm hurts, it's one thing, but if your doctor wants to see a picture of something inside your body, it's a pretty good chance you should get that picture taken. Right. And we have thousands of open orders. Imagine a scenario where, I'm right about the age where I needed a colonoscopy recently. And when I did, I got 3 different calls over the course of the couple months leading up to the procedure where they were saying, hey, do you know where to go? Do you have a ride once you're there? Because you can't have the procedure unless you have a ride there. Is the medication working? Do you have any questions? Did you pick it up? All these touch points. And every time it was a person calling me on the phone, a human being, and God bless them, I asked them, because I'm obviously in the system, like, how often do you make these calls every day? And she was like, every day, dozens and dozens of times. Wow. That's the sort of thing we're going to start to do next, is help an agent have those exact conversations and answer patiently all of your questions and be able to reach out to you multiple times. That's not only saving efficiencies for our system, but it's also taking an environment where we have a lot of no-shows because of all these things and closing those no-show gaps, because now we have a better chance of getting a hold of you and more time to talk to you.
So what informs the hospital management that there's these inefficiencies? I mean, does the executive leadership know where they're losing money, or is there something within the organization where, employees can populate, because that's something we're trying to do here at Roundstone, which is, I'm a big believer, I'm a fan of this book called The Founder's Mentality. And one tenet of that book is what's called frontline empowerment, which is the idea that you get your best information and your best innovation from the folks at the front line. But you have to have them speak up. They see it. You have to have them develop a mentality of being a founder where they want to fix something that's broken. I mean, does a hospital know where they're losing money?
So first of all, I love that mentality. We call it the wisdom of the bedside. Okay. Right. It's same way.
Yeah, we don't have any beds here.
There you go. You got folks out there who know what. Yeah, you're right on the edges of where you're talking to your customers and making real things happen. I love that, and I think an awful lot of organizations, not just healthcare systems, believe that. And now you're going to get. And I'm not going to lean into sort of my leadership philosophies because you'll get me started. But I will say that leaders who understand that ideas come from the top or bottom and move up to their eyes versus ideas cascading down because they believe they know everything,
right,
are the difference between successful leaders and leaders who are going to struggle, I think, ultimately in this world. And so the fact that you've set that environment up is great. But you asked a specific question, like, how do we know those things?
Yeah, how does a hospital know?
How does a hospital know?
Yeah.
The old-fashioned way is to do a bunch of listening and to kind of go back and forth between the top level, because a lot of our executives, by the way, are former doctors. They've worked their way up in the system. They've worked in hospital systems, so they understand, and they really don't always, I mean, they have a pretty good sense for what's going on out there. So in many cases, they believe they are the wisdom of the bedside. Right. All right. So there's a constant interplay between what the priority is at the top, what it is at the bottom, and how that functions. And together, that creates a lot of confusion about priorities when it comes to transformation. Because that's what you're really asking, right? Is how do you prioritize your scarce resources and efforts to apply them to the things that matter most? Well, we know this is a problem. And I won't say that UH has solved it entirely. I think we have a pretty good environment where we honor the wisdom of the bedside. But we have identified a real need to create, I believe, tools that can do this better. I've long believed, and again, I mentioned I've been in lots of industries. I've seen this problem everywhere where industries have a hard time organizing around their most pressing problems. For a long time, it felt like it was just going to be the old comment box, reading through them, listening, walking around the cubes, just kind of using an artful management style to tease that out. But with the advent of AI, and I hate to bring us back to this, but I really believe that there's a lot of power in it, we've developed tools that allow folks to come in and talk about either an idea or a problem, and the system will, the LLM we've built, the large language model we've built, will take their submission, strip it out into the problem statement. What problem are you trying to solve? Create a record, and then allow that record to be put in front of groups of people who are alternately trying to solve different problems throughout the system and move that record through, maybe combine them, maybe look at them individually, and start to prioritize those to find what we call high value problems, which are the big important ones, the ones that can move the needle a lot and that need to be done now. We have a system in place called we're calling it the high value problem engine, but that's because I named it and I'm terrible at naming things.
I know a good marketing person you should talk to about a name for that.
I think we should bring her in.
You might know her too.
We should bring it in and fix it. And it needs help with the name. But the cool part is that as a prototype, as a beta, it is really providing a lot of value so far, and we're looking to potentially commercialize it for lots of not just other healthcare systems, but other industries who might be suffering with the same thing.
I think it's positive in a lot of ways. That makes the employees feel part of the solution and engaged, and there's a lot of benefit. Well, I'm glad to hear that, because one of the things that as a payor, and that's what Roundstone is we are a health insurance company. A lot of times we scratch our heads that hospitals don't have a real good idea of where their costs are, or what's driving them, or where they're making money, where they're losing money. And so if there's tools being introduced that allow them to be a little more strategic in how the business is run, it'll trickle down to the payors eventually, I would guess.
That's our hope. I mean, we understand that our colleagues in finance and in strategy really have a huge job when it comes to understanding everything that's going in the hospital. I mean, you just mentioned, the struggles or the frustrations as a payer, understanding the costs of our system and the prices and the way we kind of come up with them. It is absolutely just as confusing as a payer as it is internal to the system, because with 35,000 caregivers across our 28 hospitals, and a ton of complexity in the payment structure within the government and combined with multiple sort of private insurers, we have a big job ahead of us when it comes to really getting our arms around these things. I hope that, my hope for some of these government edicts, the things that they're pushing are on pricing transparency. I know this really scares a lot of my colleagues, and there's a lot of reasons why it really, draws a lot of alarm, but I think it's nothing but good as an impulse to try and make it clear what we are all paying for healthcare. Part of the challenge is right now, it's kind of set up to, and you've seen these, this better than I do, right? We give the top line price, and then we go back and we negotiate it down. And the fear is that if you give a actual, like when I say actual, I don't mean actual, I mean the price that it eventually would be, if you start there, you might be negotiated down farther, and then that's not the way negotiations work. So there's a lot of transparency and trust building that needs to happen in the equation, I think. And I hope that I hope technologies can help us get there. I've already seen agentic tools talking with each other between hospitals and payors that get to much more efficient outcomes, and help us all win. Yeah,
we believe some of the tools today are helping with that transparency, and we're big fans of finding out what the cash price is,
exactly
what things cost. It's interesting to me. We were talking about Connected Care, and when you talk in the industry, the payor industry, they always point to the labor costs of hospitals as what's driving up so much of the healthcare costs. And so, when they say, well, why are healthcare costs supposed to go up 9% this year? It's one of the bigger numbers in a while. And they always bring up COVID and the labor costs and the shortage of nurses and caregivers. Well, what's kind of cool is your innovation is kind of attacking that head on. And maybe if you continue to chip away at that inflationary number will go down, or at least that's the hope. But, a lot of good stuff. And it's encouraging that the providers are attacking it that way. Because, I think, at the end of the day, payors want to understand it's going to cost. It's just, they just want a little more line of sight into what's driving those costs. And boy, I would love nothing more than a cash pay. Now, I will say AI is helping us figure that out. I mean, we're able to assemble the costs across the country now with the help of AI. So that's all pretty good stuff.
And I wouldn't be surprised if there's a future in which payers know the price even better than some healthcare systems who aren't getting on board with these technologies and understanding how powerful they are in terms of creating visibility to a lot of complex data.
Yeah, that's pretty cool. So let's talk about the future. All right. Where are we going? What's next for a smart hospital?
I think well, depends on which kind of hospital. I'll start there, actually.
Okay.
So I think there are some hospitals that are going to embrace technology and lean into it without fear, understanding that there's a real path forward, that you can make thoughtful decisions about that experiments can illuminate for you and how that experimental path can de-risk things. I think that the hospital systems that put together really smart transformation and innovation systems have a very bright future, right? I think the systems that do not, that lean on this idea of sort of brute force, either we install something or we don't, either kind of have a relationship with a vendor or we don't, are gonna struggle because without an experimental mindset and an understanding of how to de-risk things, I think that's gonna be a big differentiator between the healthcare systems that struggle and the ones that succeed. I think when we talk about the future of healthcare just kind of broadly, first of all, we know some trends. We know the population is going to age. We know that healthcare tech is going to continue to get expensive. I mean, we just know that. But we know also that there's technology that can help dramatically change the equations around cost and efficiencies. And if we can embrace that, I think we will start to see, I hope we will start to see the tide turning when it comes to our ability to care for the growing number of people who are going to need it.
Pretty cool. Pretty cool. Now, one of the things that we hear a lot is how there's kind of the haves and the have-nots when it comes to hospitals, if you will. Yeah. And there are a lot of hospitals, a lot of them in rural America gets a lot of attention. Are these kind of innovations and ideas, I mean, are they available to any hospital? Or, I mean, I can just hear some hospital CEO somewhere saying, this is great for university hospitals. They're one of the country's premier organizations, but there's just no way we can do it. We're a 200-bed facility in Oklahoma. There's just no way we can pull this off. What are your thoughts on that idea?
That is a great question. And when it comes to rural hospitals, or have-not hospitals, and I think sometimes those are different, oftentimes they're the same. The technologies we've talked about can be even more powerful for them. Imagine a virtual nursing network that not only applies virtual nursing capabilities to a hospital that might not have the resources they need, that they would like to have to provide all the care they need, but imagine that same connected care environment allowing a specialist to come in and out of a room from a central facility in a larger city nearby, who can come in and talk to a patient. Imagine a person in a rural hospital who has to make a really important decision about their care, and their care team is there, but their child is in one part of the country, and another child is in the other part of the country. Well, a connected care environment can bring them all together with a simple hyperlink. Right? These are the sorts of things that allow remote areas to provide world-class care. Now, you're saying, boy, they don't have, sure, university hospitals can do it, but how can I do it? I'm a 3-hospital system out in a remote area. Well, there's a couple things. One, the cost of these technologies is going to continue to come down, and as larger systems like university hospitals, as forward-thinking systems like UH look into these tools, it's going to become clearer and clearer that it is possible to generate real returns without the risk. In other words, we're going to keep publishing and telling a story about how a connected care environment, which is really expensive to install when it's the first one, which is really scary to install when you don't know the outcomes. We're going to be able to say, this is how you do it better and more efficiently. This is how you make money with it. These are the financial models that justify it. And oh, by the way, the technology is now more common, and so it's easier to attain. I'll say that. So generally speaking, the larger systems really are, hopefully, systems like ours are trying to share not just a better care model, but also insights about how to make that better care model affordable. There's another piece of the puzzle, and it's something that my boss and mentor, Dr. Peter Pronovost, it says all the time. So Dr. Pronovost is the Chief Clinical Transformation Officer at University Hospitals. I report to him. And he talks a lot about generating what he calls venture philanthropy. Now, what does this mean? Hospitals are pretty good at maybe some are, some aren't. Generally speaking, historically, how do hospitals use philanthropy? They go out, they get it to name a building, right? Yeah, oh yeah, I'm going to buy a building. I'm going to put my name on this wall. He thinks about philanthropy different. He says that philanthropy should be used to drive returns. Now, what returns are we talking about? Philanthropy is not a return generating enterprise in the sense that it's not an ROI, an investment, but it can be a return generating enterprise in terms of the outcomes that you want to see. How many conditions did you improve? How much cost did you take out of the system? How many lives did you save? Right? If we start to think about philanthropy in terms of a hospital context around generating returns and value instead of names on buildings, we will start to see tremendous growth in our ability to experiment. All of the things I just described to you are only possible not because University Hospitals is a large system. It is only possible because the Veal Foundation, a philanthropic organization here in town, had the vision and the guts to give us $20 million to establish the Veal Healthcare Transformation Institute. I'm the executive director of this institute. Peter's the president. We have founded this institute with the express purpose of driving transformational change inside of our organization. And the gift that they gave us is not going to a building. It's not endowed. It's not meant to be perpetual. It is meant to be spent. In other words, our institute only has as much runway as my ability to not only drive value for the system, but also generate other people's interest in venture philanthropy. This is a completely new way to think about it. And as you're thinking about, if you're an executive out there wondering, like, how do I lean into experiments? Ask the philanthropic engines within your communities if they're interested in the idea of venture philanthropy and returns based on experimental outcomes. You might find some interesting conversations.
Really intriguing.
Yeah, it's fun.
I find that really that's pretty cool. I couldn't agree with it more. Instead of bricks and mortar, when you were talking, I kept thinking it's like that movie. Build it and they will come. It's the opposite of that. It's like let's invest for ideas. And I know at Roundstone, our philanthropy is for organizations that are really taking problems and trying to innovate and do approach it differently. So your boss is a smart guy. I like that idea. Yeah, that's good. Hey, is there anything we haven't talked about that you want to make sure we cover? Any questions you have for me, or anything you want to know about the payor life or Roundstone or anything like that?
Well, I'd love to know from a payer's perspective, like what does it look like when you look at providers generally? I mean, maybe not sort of generalize it beyond UH in terms of their approach to innovation and transformation. What do you see when you see the landscape, and what do you hope happens? Well,
it's something I say all the time. One of the best things about healthcare is that if you chase quality. So I mean, as a payor, that's number one. We want our members to go to the highest quality available to them. But we see when they do that efficiency follows quality. So to me, like when people say, everyone complains about healthcare these days because the costs are going up, but one of the biggest positives is that as a consumer, if you chase the highest quality, you will get value, and value follows that. So that's a philosophy Roundstone has. I like to think most payors are like that, but it's certainly something we believe in at Roundstone. But at the same time, we do see inefficiencies. We see times in which the billing and the costs don't match up. Or, one of the areas that are easy is, listen, hospitals are businesses in a lot of ways, and they make mistakes. I mean, billing departments at hospitals make mistakes. Roundstone makes mistakes. I haven't been in any organization in my career where mistakes don't happen. So sometimes it's like almost like, you're not allowed to say that the hospital made a mistake on a billing, but it does happen. So as a payor, we pay close attention to that to make sure things are accurate. We make sure that the things are delivering as value. thing. There is a line interest. No one wants a readmission. The provider doesn't want a readmission. We don't want a readmission. Those are the costliest things. People don't want to go to an emergency room if they don't have to go to an emergency room. We want folks to have primary care relationships because we think that's long-term health. So we're very much aligned with almost all providers. Where we get sideways is if there's quality issues, where there's mistakes, or where, there's just, it doesn't make sense what's being charged. And at that point in time, unfortunately, we're a little different than your typical payor. We're not only trying to become aligned with the providers, but we're aligned with our employers, and we're employer first. And so we're in a marketplace where there's some 800-pound gorillas that maybe try to beat up some of the providers. That's not what we're about. We're really about trying to find the best outcome for the employer and the employer's employees, or your patients, our members, that kind of thing. So, we view you as an important part of the ecosystem, and we want to partner with you. I love hearing what you're doing, because you're driving down the operational costs, and you have a shot. I mean, listen, our customers don't like it when when we price risk, we put a thing in there called medical trend, which is a fancy word for inflation. Yep. And we want that to go down. We don't like it at 9%. That's bad for our customers. So things you're doing, it's very encouraging to hear you're helping. You're helping address that. So anything we can do to support that, we will. That's the.
Well, there's a lot of alignment between payers and providers in that world, right?
Yep.
Efficiencies, reducing errors,
Right.
In not only clinical errors, but in billing and those sorts of things. I think we will continue to be aligned on how to do that best. Whenever I've seen, and whenever I've been able to work inside UH with payers around solving problems together on the same side of the table, really cool stuff has happened.
Right.
And I hope that happens more and more.
That'd be good. Well, Brandon, we're really happy you joined us. Took the time to drive out here to Rocky River and the cold weather, and enjoyed the conversation. Hope to have another one down the road, and thanks for joining us.
My pleasure. Thanks for having me.